Welcome to the deep dive. Today, we're taking a closer look at thoracic aortic diseases, specifically those affecting the descending thoracic aorta. These conditions, unfortunately, they're a pretty significant cause of mortality, but, there's been a real game changer. Thoracic Endovascular Aortic Repair, or TEVAR. This approach, it's minimally invasive, and it's largely replaced traditional open surgery, and really for good reason, the outcomes for patients are just much better. So, our mission in this deep dive is to give you a clear, concise understanding of the Society for Vascular Surgery's clinical practice guidelines for TEVAR. We'll be breaking down how these guidelines apply to descending thoracic aortic aneurysms and, well, other specific aortic issues, kind of giving you a shortcut to the current best practices. Here's our roadmap. We'll start by understanding, the dramatic shift from open surgery to TEVAR. Then we'll dive into the essential diagnostic imaging needed for precise planning. Next, we'll explore the specific situations where TEVAR is recommended for various aortic pathologies. A crucial segment will focus on strategies to minimize risks like spinal cord injury and kidney damage. And finally, we'll cover optimal access techniques and the long-term surveillance protocols that are, well, essential for success. This deep dive is really designed to elevate your understanding and help inform your clinical decision-making. Okay, so let's unpack this a bit. The guidelines make it really crystal clear. TEVAR has truly revolutionized how we treat descending thoracic aortic disease. But just how big a shift are we talking about, really? And what are the foundational ideas driving this change?
Oh, it's a massive shift. I mean, historically, open repair. It was a physiologically demanding operation, a really big deal for the patient. It came with, frankly, high rates of mortality and serious complications like paraplegia, paralysis, and kidney failure.
Right.
Just to give you some context, elective open repair in the U.S. historically had an overall mortality rate floating around 22%,
Yeah.
which is quite high. Now, in stark contrast, TEVAR has consistently shown lower rates of complications and death, shorter hospital stays, and significantly better short-term survival.
So, okay, if the benefits are that clear, what's the definitive guideline? Is TEVAR pretty much always the go-to now?
Well, for most elective descending thoracic aorta aneurysms, the guidelines are quite unequivocal. TEVAR is the preferred approach, especially, and this is key, for patients whose anatomy is suitable for the device.
Okay.
And this isn't just, a slight preference. It's a strong recommendation. It's grade 1, high-quality evidence backing it up, precisely because of those reduced complications and better short-term outcomes we mentioned. What's also fascinating, and a bit different from open repair, is that with TEVAR, the decision largely hinges on whether the patient's specific aortic anatomy allows for the device, less so on their overall health status sometimes.
Ah, interesting. So anatomy is king here.
To a large extent, yes. It means that for isolated lesions in the descending thoracic aorta, TEVAR is now considered the primary method of repair. And that's not just for planned surgeries, but also in urgent emergent situations.
So just to briefly recap this paradigm shift, we're seeing a really clear preference for TEVAR over open repair. And this is driven mostly by those superior short-term outcomes, less burden on the patient, and as you said, a strong focus on anatomical suitability for the endovascular device itself.
Exactly right. That sums it up well.
Okay, let's maybe test your understanding with a quick clinical scenario. A 72-year-old patient presents with an asymptomatic 6.0 centimeter descending thoracic aortic aneurysm. It was discovered, incidentally. The patient has favorable aortic anatomy for endovascular repair and is considered low risk for the procedure. What is the most appropriate initial management strategy based on these current Society for Vascular Surgery guidelines? Is it A, immediate open surgical repair? B, close observation with yearly imaging? C, thoracic endovascular aortic repair? Or D, aggressive blood pressure control and lifestyle modification only? Take just a moment to think about that.
Okay, the correct answer here is C, thoracic endovascular aortic repair. The guidelines strongly recommend TEVAR for asymptomatic patients with a descending thoracic aortic aneurysm when it's larger than 5.5 centimeters, specifically in low-risk patients who have suitable anatomy.
Right, that 5.5 threshold.
Exactly. And given TEVAR's proven benefits over open repair, reduced complications, lower mortality, it's definitely the preferred choice in this scenario.
Okay, so with TEVAR being the preferred path, getting that detailed, precise picture of the patient's anatomy sounds absolutely critical. What's fascinating, like you mentioned, is how these guidelines leverage advanced imaging, not just for diagnosis, but really for meticulous planning, setting the stage for success, as it were.
You've really hit on a core point there. The diagnostic process is pretty highly structured now. For patients considered at lower risk of a thoracic aortic aneurysm, maybe based on history and physical. A chest X-ray might be a reasonable first step, mainly to rule out other things.
Okay.
But for high-risk patients, perhaps those with symptoms suggesting a thoracic aortic aneurysm or an acute aortic syndrome, then urgent imaging, usually computed tomography angiography or CTA, is strongly recommended.
CTA being the key.
Yes, it's fast, it's efficient, and it's great for that initial preoperative planning. While, magnetic resonance angiography, MRA, and transesophageal echo can be used, CT is typically preferred in those acute settings.
Right. So once TEVAR is actually on the table, what kind of detailed imaging do the guidelines call for? It sounds like it goes way beyond just a basic diagnostic scan.
Oh, it definitely does.
Right.
When you're seriously considering TEVAR, the guidelines strongly recommend a fine-cut CTA, and that's of the entire aorta, including the iliac and femoral arteries down in the legs.
Fine cut meaning?
Meaning incredibly detailed scans, sub-millimeter pixel spacing, ideally 2-millimeter cuts or even thinner. This level of detail is crucial for precise three-dimensional planning. You also need a CTA of the head and neck. That's to understand the anatomy of the vertebral arteries, which, as you know, are important for blood supply to the brain and spinal cord. It's really about meticulously visualizing every single detail.
And what role does software play in all this detailed planning?
That's where it gets really innovative. The guidelines strongly recommend using three-dimensional centerline reconstruction software.
Okay.
So imagine literally tracing the very center line of the vessel on the computer, kind of straightening out all its natural curves and twists.
Right, to get true lengths.
Exactly, to get accurate lengths and diameters without being fooled by the tortuosity. This software is pretty much indispensable for precise measurements, planning where the stent graft will land the landing zones, and really understanding where the branch vessels take off. Now, for patients who have severe contrast allergies, MRA is suggested as an alternative for that preoperative planning.
Makes sense.
And then during the procedure itself, intravascular ultrasound, or IVUS, is recommended.
IVUS, so that's inside the vessel.
Precisely. It gives you real-time, very precise assessment of those landing zones. It's particularly useful when other imaging isn't crystal clear, or if you're trying hard to minimize the amount of contrast dye used.
And what about checking the heart's function before all this?
Good question. For elective TEVAR cases, if a patient has, say, unexplained shortness of breath or maybe known congestive heart failure that seems to be worsening, assessing their left ventricular function with a transthoracic echocardiogram is suggested.
Just to be safe.
Exactly. It helps ensure their heart is in the best possible shape before undertaking the procedure.
Okay, so just to summarize this imaging section, advanced high-resolution imaging, especially that fine-cut CTA with the 3D reconstruction, is absolutely critical. It sounds like the cornerstone of precise pre-TEVAR planning. It ensures optimal device sizing, deployment, and the guidelines also clearly outline alternatives like MRA or IVUS for specific patient needs like those contrast allergies or tricky intraoperative assessments.
Exactly. Precision is really the name of the game here.
All right, let's consider another board-style question. A 58-year-old male with a known descending thoracic aortic aneurysm is being evaluated for elective TEVAR. He has a history of a severe contrast allergy. Which imaging modality is most appropriate for his preoperative planning given the specific allergy? Is it A, standard chest X-ray, B, transthoracic echocardiography, C, contrast-enhanced magnetic resonance angiography, or D, intraoperative intravascular ultrasound only? Take a moment.
Okay, the correct answer here is C, contrast-enhanced magnetic resonance angiography. The guidelines specifically suggest contrast-enhanced MRA for preoperative planning in patients who have a severe allergy to that iodinated contrast material used in CTAs.
Right.
While, as we discussed, intraoperative IVUS is helpful, especially for minimizing contrast during the case, it's not really the primary tool designed for that detailed anatomical preoperative planning phase. MRA fits that bill better when CTA is contraindicated due to allergy.
Moving on. It's clearly not just about the procedure itself. It's about knowing when exactly to intervene. What's really fascinating here is how the guidelines delineate specific thresholds and management strategies for different types of thoracic aortic disease.
That's a crucial point, absolutely. For the straightforward asymptomatic descending thoracic aortic aneurysms, the strong recommendation, grade 1B evidence, is for TEVAR when the maximum aneurysm diameter goes beyond 5.5 centimeters. But that's specifically in low-risk patients who have favorable anatomy.
Okay, 5.5 in low risk. What about higher risk patients?
Right. So for patients who are deemed to be at very high risk of complications from the procedure itself, death, renal failure, paraplegia, The guidelines suggest this is grade 2C, considering slightly higher aortic diameter thresholds for intervention. The thinking there is that in some very high-risk individuals, the natural history risk of the aneurysm might actually be lower than the risk posed by the intervention. It's a risk-benefit calculation.
That makes sense. Now, what about some of those other conditions, maybe more acute but potentially stable things like intramural hematoma or penetrating aortic ulcer?
Right. Intramural hematoma, IMH, and penetrating aortic ulcer, PAU. The approach here is definitely more nuanced. For an asymptomatic IMH, the initial strong recommendation, grade 1B again, is actually close observation, very strict blood pressure control, and follow-up imaging.
So wash and wait initially.
Exactly, because IMH can be quite dynamic. Sometimes it resolves on its own, but it's also associated with aortic dissection, which is obviously a very serious tear in the aorta, so you watch it closely. However, if patients with either IMH or PAU develop persistent symptoms or complications like rupture or expansion, or just show evidence of disease progression on their follow-up imaging despite good blood pressure control, then TEVAR is strongly recommended, grade 1B.
Okay, so intervene if it's causing trouble or growing?
Precisely. And for certain asymptomatic PAUs, specifically those with high-risk characteristics for growth or rupture, think maybe depth greater than 10 millimeters, or a diameter over 20 millimeters, TEVAR may also be suggested, though that's a weaker recommendation, grade 2B.
Got it. And what's the approach for infected aortic aneurysms, the ones often called mycotic aneurysms?
Yeah, those are challenging. For symptomatic mycotic or affected thoracic aortic aneurysms, TEVAR is suggested, grade 2C, really as a temporizing measure.
Temporizing,
Meaning it can be life-saving in acute emergencies. Like if one ruptures or forms a life-threatening fistula into the airway or esophagus, it can bridge the patient to more definitive treatment or control the immediate sepsis. But it's important to understand that the current long-term data demonstrating sustained benefit for TEVAR as the sole treatment for this specific indication. Well, it's limited. Infection control remains a major challenge long-term.
Okay, so to quickly summarize this section on specific indications, we've outlined the diameter thresholds for asymptomatic aneurysms, that nuanced dynamic management for IMH and PAU, starting with observation, and then the often temporizing role for TEVAR in those really difficult symptomatic infected aneurysms.
Precisely. It's all about tailoring the intervention or lack thereof initially to the specific pathology and the individual patient's risk profile.
All right, let's move on to our next board-style question. A 65-year-old patient presents with an incidentally discovered intramural hematoma of the descending thoracic aorta. The patient is asymptomatic and hemodynamically stable. Initial imaging shows no evidence of complications or progression. What is the recommended initial management for this patient according to the guidelines? A. Immediate thoracic endovascular aortic repair. B. Open surgical repair with follow-up imaging. C. Close observation with hypertension control and follow-up imaging. Or D. Anticoagulation therapy. Take a moment.
Okay, the correct answer is C. Close observation with hypertension control and follow-up imaging. For these asymptomatic, stable patients with an isolated intramural hematoma, the guidelines strongly recommend, grade 1B, that initial management should be close observation, really strict blood pressure control, and serial follow-up imaging.
Right.
Intervention, like TEVAR, is typically reserved for those who develop symptoms or complications or show clear signs of disease progression on those follow-up scans.
Okay, now here's where it gets really interesting, I think. TEVAR, while it's less invasive than open surgery, still carries some critical risks, especially potential injury to the spinal cord and other vital organs. The guidelines seem to lay out incredibly detailed strategies to protect patients during these procedures. Let's dive into some of the most complex aspects of TEVAR, maybe starting with spinal cord injury. That's always a major concern.
It absolutely is. Spinal cord injury, SCI, is indeed a devastating complication. And while TEVAR certainly has a lower rate compared to traditional open repair, it still happens. It's multifactorial, often involving the complex blood supply network coming off the aorta, particularly the intercostal arteries feeding the spinal cord. Key risk factors that increase the chance of SCI include covering extensive lengths of the aorta with the stent graft, particularly if it's over 15 centimeters, and also if the patient already has existing disease or previous surgery in other parts of the aorta, like the infrarenal aorta.
Right, because that might compromise collateral blood flow.
Exactly. The collateral network is crucial.
So given these risks, what are the primary strategies recommended in the guidelines to actively protect the spinal cord during these complex TEVAR procedures?
Okay, the guidelines are very specific here. For patients identified as high risk, it's strongly recommended, grade 1B, to maintain controlled hypertension, during and immediately after the procedure.
Controlled hypertension, meaning keep the pressure up.
Yes, specifically keeping the mean arterial pressure, or MAP, above 90 millimeters of mercury. The idea is to maximize perfusion pressure to the spinal cord. This is part of a dedicated spinal cord protection protocol. And importantly, also strongly recommended, grade 1B again, for these high-risk TEVAR cases, is prophylactic cerebrospinal fluid, or CSF, drainage.
CSF drainage, tell us a bit more about how that helps.
Sure. CSF drainage involves placing a temporary lumbar drain to remove a small amount of cerebrospinal fluid. This lowers the pressure within the spinal canal, which in turn can increase the pressure gradient driving blood flow into the spinal cord arteries. It effectively improves spinal cord perfusion.
And who qualifies as high risk for needing these measures?
High-risk factors include things like that extensive aortic coverage we mentioned, previous aortic surgeries, either open or endovascular, known compromised blood flow to the pelvis, which supplies collateral flow, and crucially, any planned coverage of the left subclavian artery. Diseased or occluded vertebral arteries also contribute to risk.
Okay, speaking of the left subclavian artery, or LSA, that seems to come up a lot. Why is managing the LSA so complex, and what are the big concerns if you have to cover it with the stent graft?
That's a really vital area, you're right. The LSA often needs to be covered, maybe in up to 40% of cases, just to achieve an adequate seal for the proximal end of the stent graft. You need a good landing zone.
Right, seal is paramount.
It is. But the main concerns with intentionally covering the LSA are several-fold. First, spinal cord ischemia, as the LSA contributes significantly to spinal cord blood flow via the vertebral artery and potentially thyrocervical trunk collaterals. Second, stroke, particularly if the vertebral artery origin is involved. Third, arm ischemia or claudication. And fourth, issues with the vertebrobasilar system, which supplies blood to the back of the brain, potentially causing dizziness or balance problems. You can think of the LSA as a critical on-ramp feeding multiple vital vascular highways: the arm, the posterior brain circulation, the spinal cord.
Good analogy.
Covering it without rerouting that traffic, without revascularization, can potentially starve those important downstream territories.
So what do the guidelines recommend then regarding LSA revascularization? Do you always need to bypass it?
Not always, but often. For elective TEVAR, where LSA coverage is planned and necessary, the guidelines suggest grade 1B, revascularizing it either before or at the same time as the TEVAR procedure, usually via a carotid subclavian bypass or transposition. And they very strongly recommend grade 1B again, LSA revascularization, when the patient's specific anatomy means that covering it would clearly compromise blood flow to vital structures.
Can you give some examples of those situations?
Sure. Examples include things like a patent left internal mammary artery graft supplying the heart from a previous bypass, or if the left vertebral artery is dominant or terminates in a critical brain artery, like the posterior inferior cerebellar artery, or if the right vertebral artery is absent or diseased. Also, situations like a functioning dialysis access in the left arm, prior abdominal aortic surgery where lumbar arteries were sacrificed, planned extensive descending aorta coverage, known blockage of the hypogastric arteries supplying the pelvis, or even just being a younger patient where long-term durability is paramount.
Okay, that's quite a list. What about emergencies?
Right. For acute thoracic emergencies like a rupture or dissection requiring urgent TEVAR and LSA coverage, the decision to revascularize is more individualized. It depends on the specific anatomy, the urgency of the situation, and the patient's overall condition. Sometimes you have to cover it emergently and deal with potential consequences later, or perhaps stage the revascularization. It's a judgment call. Grade 2B recommendation for individualization there.
Okay, moving beyond the spinal cord and the LSA. What about kidney protection? We mentioned contrast use earlier. How big a concern is kidney injury?
Acute kidney injury, AKI, is a very serious complication after TEVAR. It's actually a strong predictor of increased mortality.
Wow, okay.
Risk factors are what you might expect: advanced age, pre-existing chronic kidney disease, diabetes, congestive heart failure, and notably the amount and type of contrast dye exposure during the procedure and imaging. Blood loss also plays a role.
So how do we protect the kidneys?
Well, the guidelines emphasize proactive measures. They strongly recommend, grade 1B, careful pre-procedure planning, specifically aimed at minimizing contrast material use. This includes leveraging technologies like intraoperative CTA overlay or fusion imaging and using IVUS where appropriate. They also strongly recommend, grade 1B, using non-ionic hypoosmolar contrast material, the kind that's generally considered less toxic to the kidneys, and minimizing the total volume used, especially the intra-arterial injections, particularly in high-risk patients.
Any other tips?
Yes, there are weaker recommendations. Grade 2, suggesting potentially diluting the contrast material, say 50% or 70%, if it still provides adequate image density. And also using on-table mapping software like road mapping or CT fusion overlays to help locate target landing sites accurately and minimize the need for repeated contrast injections to check positioning.
And one more area of potential organ injury, mesenteric ischemia. What if the celiac artery needs to be covered to get a good distal seal?
That's another important consideration. Celiac artery, or CA, coverage might be necessary in maybe 4 to 6% of TEVAR cases, often to extend the seal zone distally. But of course, this raises concern for ischemia in the organs it supplies, primarily the liver, spleen, and stomach.
How do you assess that risk?
We evaluate the collateral blood supply, which mainly comes from the superior mesenteric artery, or SMA, via the pancreatico-duodenal arcades. This is usually assessed on the preoperative CTA, or sometimes with dedicated SMA angiography during the procedure.
And what if the collateral supply looks poor, or the SMA itself is diseased?
Good question. If there's a significant stenosis, say greater than 50%, in the SMA itself, the guidelines recommend grade 1B, preemptive stenting of the SMA. This might be done before or just after CA coverage, especially if the TEVAR device encroaches on the SMA origin or if the patient is otherwise considered high risk for post-TEVAR mesenteric ischemia. Also, if there's a high anticipated risk of ischemia in the celiac territory itself, for instance, if those critical collateral pathways from the SMA aren't clearly visualized on imaging, then the recommendation, grade 1B, is to perform open or endovascular revascularization of the celiac artery before proceeding with the TEVAR that covers it.
Proactive revascularization.
Exactly. And even if you do cover it, with or without revascularization, meticulous vigilance for any clinical or biochemical signs of mesenteric or hepatic ischemia after the procedure is absolutely paramount. You have to watch the patient very closely.
So let's just take a moment to synthesize this entire section on risk mitigation. It's quite complex. We've really explored multi-pronged strategies needed to minimize critical risks during TEVAR. This includes those multimodal protocols for protecting the spinal cord, things like controlled hypertension and prophylactic CSF drainage. It also covers the careful, individualized decision-making around revascularizing the left subclavian artery to preserve vital perfusion to the arm, brain, and spinal cord. Furthermore, we discussed meticulous contrast management strategies aimed at protecting kidney function, like minimizing volume and using less toxic agents alongside adjuncts like IVUS and fusion imaging. And finally, we touched upon the proactive assessment and potential revascularization strategies needed to maintain mesenteric perfusion when planned coverage of the celiac artery is necessary.
This really detailed, comprehensive approach to anticipating and mitigating these perioperative risks is absolutely crucial for optimizing patient outcomes after TEVAR.
All right, another board-style question for you, focusing on these risks. A patient is undergoing elective TEVAR for a descending thoracic aortic aneurysm. The plan requires extensive coverage of the descending aorta greater than 15 centimeters, and it also includes planned coverage of the left subclavian artery. Which of the following spinal cord protection strategies is most strongly recommended for this high-risk patient? A. Continuous somatosensory evoked potential monitoring alone. B. Prophylactic cerebrospinal fluid drainage and controlled hypertension. C. Staging the coverage of the descending aorta over multiple procedures. Or D. Routine use of naloxone postoperatively. Take a moment.
Okay, the correct answer here is B, prophylactic cerebrospinal fluid drainage and controlled hypertension. For these clearly high-risk TEVAR cases characterized by extensive aortic coverage, more than 15 centimeters, and planned left subclavian artery coverage, the guidelines strongly recommend both prophylactic cerebrospinal fluid drainage, recommendation 18, grade 1B, and maintaining controlled hypertension with a mean arterial pressure greater than 90 millimeters of mercury, recommendation 17, grade 1B. These are considered key combined components of an effective spinal cord protection protocol in this specific high-risk scenario.
Okay, finally, let's talk about actually getting the job done, how we physically gain access to the aorta to deliver the device, and then critically, how we keep an eye on things long-term after the procedure. So what does this all mean for optimizing access and then ensuring durable, lasting results?
Right, access. It's a critical aspect, and access-related issues used to be a more common source of morbidity, though thankfully it's decreasing somewhat as the delivery devices get smaller and more flexible. For traditional open femoral artery access, the guidelines recommend grade 1B, using transverse or oblique groin incisions rather than vertical ones, mainly to reduce wound complications like infection or lymph leak.
Okay, incision choice matters. What about percutaneous access?
For percutaneous access, meaning accessing the femoral artery through the skin using needle puncture and closure devices, without a surgical cut-down, ultrasound guidance is strongly recommended. Grade 1B again. It demonstrably improves procedural success rates and decreases major complications like bleeding or pseudoaneurysm formation.
Is percutaneous always an option?
It's considered safe and acceptable, grade 1B, if certain anatomic criteria are met. Things like a common femoral artery diameter being large enough, absence of heavy calcium on the front wall where you'll puncture, no severe scarring from prior surgery, and generally a vessel diameter greater than 5 millimeters. You need a suitable vessel.
And what if the femoral or iliac arteries themselves present a major challenge? Maybe they're too small, too twisty, or heavily calcified for these large delivery systems.
That's a great question because it happens. For patients with such challenging iliofemoral anatomy, the guidelines recommend, grade 1B, considering alternative access strategies like surgical iliac conduits, basically sewing a tube onto the iliac artery to create a landing zone, or even direct punctures of the iliac artery, or the aorta itself in some cases, to facilitate device access. Importantly, this decision to use an alternative access, like a conduit, should ideally be made during the preoperative planning phase, not as a surprise intraoperatively.
Preparation is key.
Absolutely. There's also something called an endoconduit, which is an acceptable alternative in some cases. It often involves balloon angioplasty and stenting of the iliac artery first to create a smoother path or reinforce a fragile vessel before passing the large T-VAR sheath. And for extremely tortuous or seemingly impassable aortas or iliac systems, there's a technique known as the body floss.
Body floss.
Yeah. It sounds a bit strange, but imagine threading a long, stiff guide wire all the way through the aorta, maybe starting from an arm artery like the brachial or axillary, down through the thoracic and abdominal aorta, and out through a femoral artery access site.
Ah, creating a rail.
Exactly.
Yeah.
You essentially create a stable railroad track that provides strong support to guide the large, stiff TEVAR delivery system through particularly challenging, tortuous vessels. It can be very effective in difficult cases.
Okay, so that covers getting access. Now, once the procedure is done, successful, device deployed, what's the long-term plan? How do we ensure that success actually endures over time?
This is absolutely critical. Long-term surveillance after TEVAR is considered non-negotiable. It's essential due to the potential for late complications that can occur months or even years down the line.
What kind of complications?
Things like an endoleak, where blood finds a way to leak back into the original aneurysm sac outside the graft, potentially causing the aneurysm to repressurize and grow. Also, late stent graft collapse or migration, material fatigue or disruption, infection of the graft, or even the need for late conversion to open surgical repair can occur sometimes 5 years or more after the initial TEVAR.
So, lifelong vigilance. What's the recommended protocol?
The guidelines provide a very clear protocol. They strongly recommend grade 1B contrast-enhanced computed tomography, or CT, scanning at specific intervals. First at 1 month post-TEVAR, then again at 12 months, and after that, yearly for life.
1 month, 12 months, then yearly for life. Got it.
Yes. Now, more frequent imaging might be needed under certain circumstances. For instance, if an endoleak or some other abnormality of concern is detected on that initial 1-month scan, or perhaps in patients considered higher risk for late problems like those initially treated for a penetrating aortic ulcer or a ruptured aneurysm, then a repeated CTA, often with both arterial and delayed phase imaging to better characterize leaks, is recommended sooner, perhaps within 6 months.
Okay, so just to recap this final section then, we've covered the critical role of choosing and executing the right access technique, from ultrasound-guided percutaneous approaches being preferred when feasible, to surgical conduits, or even body floss for more challenging anatomy, really emphasizing that careful preoperative planning. And equally importantly, we've highlighted the absolutely non-negotiable need for lifelong structured surveillance imaging, primarily with contrast-enhanced CT scans at 1 month, 12 months, and then yearly to monitor the integrity of the repair and catch any potential late complications to ensure the long-term success of the TEVAR.
That's it exactly. Access sets you up for success. Surveillance ensures it lasts.
Okay, one final board-style question for you, focusing on that surveillance. A 70-year-old patient has undergone an uncomplicated elective TEVAR for a descending thoracic aortic aneurysm. The 1-month post-procedure CT scan is unremarkable, looks great, excellent aneurysm exclusion, no endoleak detected. When should the next contrast-enhanced computed tomography scan be scheduled according to the Society for Vascular Surgery Guidelines? A, at 6 months post-procedure. B, at 12 months post-procedure. C, only if new symptoms develop. or D, at 5 years post-procedure? Take a moment.
Okay, the correct answer here is B, at 12 months post-procedure. The guidelines strongly recommend, grade 1B, that routine contrast-enhanced CT scanning occurs at 1 month and 12 months after TEVAR, followed by yearly scans for life. So even with a perfectly normal, unremarkable 1-month scan, that 12-month follow-up CT is still a standard essential component of the recommended surveillance protocol. You don't skip it just because the first scan looked good.
Well, we've certainly covered a tremendous amount of ground in this deep dive. We've gone from the big picture strategic decision to opt for TEVAR in the first place, right down to the intricate details of patient selection, meticulous planning using advanced imaging, managing perioperative risks, access strategies, and importantly, that ongoing lifelong care required to ensure long-term success.
Indeed. It's clear that TEVAR has fundamentally transformed how we manage descending thoracic aortic disease, offering really significant advantages over the traditional open repair in many, many patients. And these evidence-based guidelines, drawing on years of data and experience, provide an absolutely invaluable framework for clinicians like you to optimize patient outcomes and confidently navigate the complexities of this constantly evolving field.
Absolutely. These guidelines provide such an invaluable framework, but, they also underscore an essential truth in medicine, I think. While we've made these immense strides with technologies like TEVAR, having a really robust foundation in understanding the natural history of these complex aortic diseases themselves, coupled with that diligent, lifelong, patient-specific surveillance we just talked about, well, that remains absolutely paramount. It makes you wonder, what further long-term comparative effectiveness research might redefine our understanding of true durability and reintervention rates for the next generation of TEVAR devices, especially thinking about our younger patients who might live for decades with these implanted technologies. What will surveillance look like for them 40 years down the line? That's certainly something I keep thinking about.